My task within the next 20 minutes will be to give you a brief overview regarding transient elastography. So, just to remind you that among the available non-invasive methods, we have two different but complementary approaches. The initial approach was the biological approach based on the dosage of serum biomarker, and later on comes the physical approach that is based on the measurement of liver stiffness, for which the initial technique was transient elastography, known as FibroScan, that is marketed by the French company called Echosens. And actually, for those who are not familiar yet with this technique, it was initially designed to measure the density of yogurt and cheese. And to make a long story short, it finally ended up measuring liver stiffness. So, what are the principles of limitation of transient elastography? Briefly, an ultrasound probe is mounted on the axis of a vibrator, inducing the propagation of an elastic shear wave. Transient elastography allows to measure liver stiffness of volume that approximate 4 cm long to 2 cm wide, and this is 100 times bigger than a liver biopsy. So the stiffer the liver, the faster the shear waves propagates. And for instance, if you have a soft liver, because what we measure is the velocity, you can see the velocity is low, and the kilopascal are low. Whereas if you have a stiff liver, as you know, it's much easier to run on concrete, so the velocity increase, and the kilopascal as well increase. So the value range from 2 to 75 kilopascal in clinical practice. So for those who are not familiar yet with the technique, this is how the results come. And I want to stress two important points. So the value is the median value of 10 validated measurements, but you should take into account two important factors. First of all, the IQR, that reflects the variability and should be less than 30% of the median value, and is the most important factor, as I will show later on. And also the success rate, that is the number of validated, the ratio of validated measure to the total number of measures should be above 60%. So let's see how it is translated in clinical practice. The failure that is defined by the software, meaning no result, is observed in around 3% in our experience. The unreliable result, not meeting the manufacturer recommendation I previously mentioned, success rate, number of valid measure, and the ratio of IQR and LSM, was almost observed in 16% of cases, meaning in total that FibroScan was not applicable in around 20% of cases. And in multivariate analysis, this was mainly related to obesity and to operator experience. So the ICSEL probe has been proposed to overcome the limitation of the regular probe, but the question is whether it's really overcome in clinical practice. So these are the results from the Rob Meyer study in Canada, 276 patients with high BMI. And you see that regarding the failure rate, the ICSEL probe overcomes the limitations of M-probe, 1% versus 16%. But regarding the unreliable result, still, in around 25% of patients, the results are unreliable with the ICSEL probe. Also, there is the cutoff issue because, as you can see on this slide, the ILSEC probe is in white and the regular probe in gray. The cutoffs are significantly different and significantly lower with the ICSEL probe by at least 1.5 kilopascal. So the question is whether which cutoff is right, the ICSEL probe or the M probe. So that means that we have to redefine all the cutoff. So that's also an issue with the ICSEL probe. So regarding the other confounding factor, as you know, Glisson's capsula is a distensible but non-elastic envelope. So if you increase the pressure within the liver, then you will increase the liver stiffness. And this has been initially shown as a confounding factor with acute inflammation. So if you have patients with hepatitis B and reactivation, or patients with acute viral hepatitis, there's a risk of overestimating liver stiffness value. It has also been shown with extrahepatic cholestasis and liver congestion, but there might be some other factor. So initially, there was a German study suggesting that food intake may influence liver stiffness. And this has been nicely confirmed by a recent study from the group of Massimo Pinzani, 125 HCV patients stratified according to the stages of fibrosis. And basically what you can see, they had a standardized meal and liver stiffness was measured every 15 minutes for 2 hours. And there was a significant increase after the meal, whatever the stage of fibrosis. So the take-home message now is that transient elastography should be performed in fasting patients. So now let's move to the performance of transient elastography. This busy slide summarizes the result in viral hepatitis, HCV, and HBV because, as you know, transient elastography has been initially validated. The index study has been performed in France in HCV patients. And basically what you can see is that the AUROCs are pretty good for significant fibrosis, but much better for cirrhosis, around 0.90 to 95. And overall, you can correctly classify around 75% of patients for significant fibrosis and 90% for cirrhosis. And this result has been confirmed since by many other groups. In NAFLD, there are less data, but this is the largest study to date, 246 patients, and basically you can see that the results are pretty much the same. So a meta-analysis to summarize this result, significant fibrosis, you can see the AUROCs are 0.84 for significant fibrosis, but as I mentioned, much better for cirrhosis, 0.94. So back to clinical practice, for instance, at a cutoff of 14.6 kilopascal, you can see that the negative predictive value to exclude cirrhosis is very high, whereas as expected, the positive predictive value is not as high. But overall, you could correctly classify and save a liver biopsy in around 90% of patients. So now, how does it compare with serum biomarker? So this is a study we initially performed where we compare in patients with Hep C, FibroScan, and 2 biomarkers, one patented biomarker, the FibroTest, that has been introduced in France initially by Thierry Poinard. I'm not sure this test is marketed in Russia. And also a non-patented test, the APRI. This is a ratio of AST and platelet count. And you can see that in this study there was no difference for the diagnosis of significant fibrosis in Hep C patients between FibroScan and the biomarker. And this has been recently confirmed in a larger study, the study by Degausse. This is also a French multi-center study, 19 centers, independent from the company and the developer of the test. Regarding cirrhosis, the situation is slightly different, as transient elastography outperforms every biomarker, including FibroTest, APRI, log index, platelet count, prothrombin index, LCLT ratio. And this has also been confirmed in the large study of Degausse. So just to summarize briefly, for significant fibrosis, the performance of serum biomarker and transient elastography are equivalent, whereas they are better for cirrhosis with transient elastography, but you have to take into account the applicability of transient elastography that is not as good as that of biomarkers. So what about combining both methods? This is the approach we use and we proposed in 2005, and actually if you use this approach, you increase the diagnostic accuracy and you increase the number of correctly classified patients. And this approach has been confirmed now by other groups. Some other groups have proposed to combine sequentially biomarkers. This is the Alfredo Alberti group in Padova. And we compare in the same population this approach. And you can see for significant fibrosis, combining FibroScan and FibroTest correctly classified a significantly higher number of patients than using this algorithm. Whereas for cirrhosis, there was no difference, around 75 to 80% of cases. So just to summarize briefly the respective advantages and disadvantages of biomarker and FibroScan. The advantages of biomarker is that the reproducibility is good, the applicability is high, more than 95%, and this is low cost and wide availability, at least for the non-patented test. The disadvantages is that none is specific of the liver. because there are just mathematical formula that are correlated with liver fibrosis. And the performance for cirrhosis is not as good as that of transient elastography. And also there is the cost issue with the patented tests such as FibroTest. The major advantage of FibroScan is that what you measure is a genuine property of the liver. And it's high performance for cirrhosis. It's user-friendly, can be performed in the outpatient clinic, very short time procedure, less than 5 minutes, immediate results, so the patients usually love it. The main disadvantage, as I've already mentioned, is a low applicability, around 80%, and the risk of false positive, especially in case of inflammation. So you have to be cautious, for instance, in Hep B. And also you require a dedicated device. So how should we use the non-invasive methods in clinical practice? This is now, when you want to make a decision to treat in hepatitis C, this is the tools that are available. HCV genotype, IL-20-LB, non-invasive methods, or liver biopsy. And initially, the Haute Autorité de Santé in France, back to 2008, so 5 years ago, recommended to use as first line in patients with Hep C, naive patient without comorbidity, either biomarker or FibroScan. And more recently, the EASL guideline have endorsed the combinations as first-line assessment of FibroScan and biomarker. And as you know, they will be updated probably by the end of this year. And so I just proposed this algorithm for clinical practice in treatment-naive, no comorbidity Hep C patients. Of course, you determine the genotype. And then the idea is to combine two unrelated methods, transient elastography plus a biomarker, whatever the biomarker. And in case of discordance that is observed in around 20 to 25% of cases, then you repeat the exam and search for explanation to discordance. And only perform a liver biopsy if the results are going to influence your management. When they are concordant, there are 3 situations. Either the fibrosis is mild, and if the fibrosis is mild, you don't need a liver biopsy. You decide for follow-up or treatment according to the genotype. When the fibrosis is severe, you should not only decide for treatment, but also for screening for complications such as HCC and portal hypertension. In between is a gray area, and you should discuss a liver biopsy again only if the results are going to influence your management. So the liver biopsy should be performed in the case of comorbidities such as alcohol or NASH, and when non-invasive method cannot be used or in any unclear situations such as discordant result of non-invasive test. So now regarding hepatitis B, the situation is slightly different, as you know. And what is different from Hep C is that with the NUC, once you start treatment, you won't stop. So it's virosuppression, it's not eradication like in Hep C. You cannot cure the patients definitely. And personally, before making an indication of antiviral treatment, I still take a liver biopsy because, as I've shown, it's not easy to discriminate between F1 and F2, and also there is a role of inflammation. But for instance, in inactive carriers, I think the non-invasive methods are very accurate, and particularly FibroScan. If you are, let's say, a value less than 5 kilopascal, it's very reassuring, and it's very unlikely that the patient has cirrhosis, because I have shown you the negative predictive value is very high. So in hepatitis B, as I've shown you, the performance of FibroScan is better, but we don't know about the combination of methods because there is very few data in the literature so far. Also, in NAFLD, we don't know also about the combination, of the FibroScan and biomarker, and we're still lacking data. So coming back to Hep C, the question is now, since we have more potent drugs, DAA, and maybe in the next future interferon-free regimen, and you can cure more than 90% of patients, is it still important to diagnose significant fibrosis? I'm not sure, because if you can cure 90 or 100% of patients, you don't care whether they have significant fibrosis or not, you're going to treat them. But still, cirrhosis will be an important endpoint because it will trigger the monitoring of complication of portal hypertension and HCC. And as I mentioned before, the value range from 3 to 75 kilopascal, and you can see that cirrhosis are around 15 kilopascal, but there is a wide range of value in cirrhotic patients. And this study was a proof of concept study that was now published 5 years ago. And basically, you can see there was a parallelism between the liver stiffness value and the occurrence of complication, suggesting that in the context of cirrhosis, liver stiffness may be of prognostic value. This has been confirmed and consistent with the nice correlation between SVPG and liver stiffness that has been initially shown by the group of Xavier Forns in Barcelona. And back to the clinical practice, good correlation has been shown as well with varices, no varices, low liver stiffness value, high-grade varices, high stiffness value, but the correlation with variceal size was not found in all studies. And just to briefly summarize, what I want to show you on this slide, that you could correctly classify around 60 to 70% of patients that is much too low to save endoscopy in these patients. So to summarize, liver stiffness is strongly correlated with HVPG and the presence of esophageal varices, but its performance are not sufficient thus far to confidently replace endoscopy for esophageal variceal screening. So very recently, we have some data from Italy and from Japan suggesting that spleen stiffness may be of better value in the context of portal hypertension than liver stiffness. And if you look at this study, you can see that the negative predictive value was very high to exclude varices, either the presence of varices or high-risk varices in this population of patients with cirrhosis. So these are preliminary data, but that might be a hint in the next future. Also, there's been some studies that have shown correlation between liver stiffness and the occurrence of hepatocellular carcinoma. This was the initial study from Japan, and this has been confirmed also by a Korean series in hepatitis B. So before concluding, I would like to give you a few perspectives. And now there are challengers for measuring liver stiffness in the clinic. The main one being ARFI. So ARFI is proposed on the commercial ultrasound by the Siemens company. And another one is the supersonic shear imaging that is proposed also on an ultrasound machine, on the Explorer machine. And for instance, there is a recent preliminary pilot study from Italy suggesting that in Hep C patients, supersonic imaging may perform better for the diagnosis of significant fibrosis at transient elastography. But as I mentioned, very soon in the context of Hep C, with the new drugs available, I'm not sure that significant fibrosis will be still a relevant point. So just to briefly summarize, the advantages and disadvantages of ARFI and supersonic. So as I already mentioned, the main advantage as compared to FibroScan is that you can implement this technique on a regular ultrasound machine, and the applicability seems better than that of transient elastography with performance that are close to transient elastography. The disadvantages is that further validation is still needed, and also the result come in meter per second, not in kilopascal, with a narrow range of value, 1 to 4 meters per second. And I'm not sure we'll be able to define clinically relevant cutoff. And also the quality criteria are not well defined. So the advantages of supersonic are pretty similar. It can be implemented on a regular ultrasound machine. There's a high range of value. Result come in kilopascal, but you can see that the range is from 2 to 150, so much higher than the FibroScan. The performance needs to be confirmed in other study. As I mentioned, the quality criteria are not well defined, and the reproducibility also, the data are limited. So these are the take-home message I would like you to take with you. So transient elastography is well validated in chronic viral hepatitis and can be used as first-line fibrosis evaluation as recommended by the EASL guideline. Combining two related methods, transient elastography plus biomarker, increases diagnosis accuracy, especially in Hep C, but this is a strategy that deserves to be validated in Hep B or in NAFLD. It's the most accurate method for detecting cirrhosis and may be of prognostic value in this setting. Although it has limitations, the main limitation being applicability in obese patients, it's a promising technique for the monitoring of disease progression, but needs to be further validated in longitudinal study. Thank you for your attention.